Hi, everyone. I am Amy Hajari Case with the Pulmonary Fibrosis Foundation, and I'm so excited to welcome you all to the very first disease education webinar event in our series for 2025. Happy New Year. I hope it's gotten off to a great start for everyone. I'm really excited. Today's topic is cross-cutting for everyone in our community. We'll be talking about pulmonary function tests and reports and what those results really mean and how we utilize them. Um, Before we get started and before I introduce our wonderful speaker, I just have a few housekeeping items I want to go over. Um, if you are new to our webinar series or the platform, the Zoom platform that we're using, if you will look at your toolbar, either at the bottom or top of your screen, you will see a couple of different functions that I'm going to point out for you. There is a Q&A button there that if you have any questions during the webinar, and those would be any technical questions, if you're having trouble with something, we can help troubleshoot audio or something like that, or if you are having a question about the topic that you would like for us to try to answer during the session or at the end of the session where we will have dedicated time for Q&A, please put those there. We'll get to as many of your questions as we're able. We also will try to respond to those questions that are technical in nature during the session. We do have some folks helping us on the back end. If you are interested in seeing or would be helped by seeing captions. Closed captioning is available on this platform. There is a button also on your toolbar. If you will open that up, you can choose to show captions. It does a pretty good job. They're not exactly right, but you should hopefully get the gist, and that should help if we're having any audio issues. The chat function is not going to be used during this session, so please go to that Q&A. We will have slides available for you guys to download before the end of the session if you would like to look at those later or take some notes. So before we get too much further into the hour, I'd like to get started with our content and introduce our speaker, Mary Beth Jamison. Mary Beth is a family nurse practitioner who's spent the past 3 years working with the Interstitial Lung Disease Clinic at Banner University Medical Center in Tucson, which is part of our PFF Care Center network. And there she split her time working in the Center for Sleep Disorders, caring for patients with various types of sleep disorders. And she was actively involved in the Tucson Pulmonary Fibrosis Support Group and the Nursing and Allied Health Network of the Pulmonary Fibrosis Foundation. She is a recipient of a DAISY Award, which is an incredibly prestigious nursing award in January of 2017 for her work as a nurse in the medical ICU. And she recently moved to Illinois and is practicing there now. So welcome, Mary Beth. Thank you so much for being here. We're excited to hear from you.
Yeah, thank you for having me. I'm really excited to be talking about pulmonary function testing. So what I really hope that most people will get out of this is just a practical kind of understanding of the pulmonary function test, because it's something that you're doing so frequently. And I really hope that you'll be able to kind of look at your own reports and then know what some of those numbers mean. A quick medical disclaimer. So just note that any of the information contained in this presentation is for informational or educational purposes only. It's not intended to be a substitute for professional medical advice. Always consult your personal physician or healthcare provider with any questions that you might have regarding your specific medical condition. So today we're going to start with talking kind of a brief overview of normal lung function. So understanding that normal lung function in order to understand the pulmonary function test. Then what are the pulmonary function tests, how to read the reports. Specifically, we'll look at some actual pulmonary function test reports. And then we'll talk about some things that you can do between testing to help with your pulmonary function test, as well as just to help with some symptom management. So to start, we're going to talk about, like I said, the mechanics of breathing, so normal lung function. So whenever we're inhaling, we're taking that big breath in. We have our diaphragm, and I like this picture here because it shows how robust that diaphragm muscle can really be. So this is that diaphragm muscle sits right under the ribs. So that diaphragm moves down, And your intercostal muscles, which are all the muscles in between your ribs, those are opening. They're opening out and up, so they're expanding, and that diaphragm is moving down. So this is helping you suck the air in whenever you're inhaling. And then whenever you're exhaling, all those intercostal muscles, those muscles between your ribs, they're relaxing, and then that diaphragm is coming back to its resting state. And this is that passive motion. So that's allowing you to push the air out. And then we have our alveoli. That's like the workhorse of the lungs, which is this here. It's at the very kind of tips of our lungs, but those are the active part of the lungs. That's where the gas exchange or the diffusion, and that's part of that pulmonary function test is measuring the diffusion. So we have our alveoli and connective tissue that's making up most of the tissue of our lungs, and we see in this image here we have oxygen diffusing into the blood vessels, and then that carbon dioxide is diffusing out to be exhaled. Whenever we're measuring lung function, when we're doing that pulmonary function test, we're not really using a pulmonary function test to diagnose pulmonary fibrosis. So, if you're, in the beginning stages, you're having these symptoms of shortness of breath or cough, and you're getting that pulmonary function test initially, that's not going to tell us specifically this is pulmonary fibrosis. It might tell us maybe better classify the type of lung disease that someone might have, but it's not going to give us a diagnosis necessarily. And then also, we don't use pulmonary function tests to differentiate between different types of interstitial lung diseases. We can't tell if it's maybe IPF or if it's maybe a connective tissue disease related ILD. So it's not going to differentiate between different types of lung diseases. And then, really we're using them to monitor your progression. So we're monitoring if a medication is working. Do we expect to see that FVC number improve, or are we looking to see if this is going to be a gradually, naturally progressive type of lung disease? So we're really using them to monitor disease progression. When we talk about normal PFT values, this is just a general kind of guideline. Normal values, of course, will change based on your age, your sex, and your height. And each of your pulmonary function test reports should have a little section where you'll see LLN, that lower limit of normal, and that upper limit of normal. So that's kind of a general guideline on each report that will tell you, where should I maybe be falling in this range. But in general, that normal total lung capacity for adults is around 6 liters, and that's for an adult male. So that can change based on your age, your sex, and your height. But that's a general guideline for a total lung capacity. And these numbers here might make more sense after we've gone through some of the pulmonary function test reports. But in general, an FVC of greater than or about equal to 80%. Or again, you can use your lower limit of normal on your own pulmonary function test to see where you might be falling. That ratio, that FVC to FEV1 ratio of greater than or equal to 70%. Our total lung capacity of about 80% or greater. Again, you could use the lower limit of normal, and then with the DLCO around 70%, or again with the lower limit of normal, which will be on your reports. So whenever we're grading maybe the severity of a restriction, this doesn't necessarily stage patients. We don't use pulmonary function tests to really stage somebody because you might have somebody that their pulmonary function test might show, let's say, moderate to severe restriction. That symptomatically, they might not be feeling that shortness of breath. So symptoms can vary from our pulmonary function test. So it's not exactly useful to be using a pulmonary function test to give a stage to our patients in all cases. So when you're looking at a report, there's going to usually be 3 main sections when you're looking at the numbers. So the first section is going to be spirometry. And that's how much air that you can move in and out, and that how quickly you can exhale. So it's just really that forced expiration. Usually the first part of the pulmonary function test that you're doing is the spirometry. Then we're looking at volume. So how much volume can your lungs hold? So we're just measuring that total lung volume and some other volume numbers. And then diffusion. So how well can that oxygen diffuse from the lungs into the blood vessels? Those are the 3 main sections. And this is what it might look like on your report. So some people's might look a little bit different. You might have some of these lung volume numbers up in your spirometry. Maybe the lung volumes come first and then your spirometry comes second. But in general, the reports will have a spirometry section, a lung volume section, and a diffusion section. So we're going to break these down today in these three sections. And even still, we're going to break them down even further to take out some of these extra numbers and make it a little more simple to go through the pulmonary function test report. Um, each section of your report will have the flow volume loops. We're not going to spend a lot of time really on the flow volume loops, but it will be on the report. Sometimes we can look at them to see, how long of a breath you are taking. We can look to see if there's like coughing, or there's other little things that we can look at in the flow volume loops. And then your trended studies is going to be on your report typically. So this is going to help you see a change over time in a nice, easy format. And you'll have your date. We're going to look at what numbers to look at in a trended study and kind of go through some examples as well. But this will be as a part of your reports as well. And then we have a section of our pulmonary function test report, this section here. So it's best. Sometimes it'll be called something a little different, but essentially this is what you are doing in your report. You have the predicted, your percent predicted, and then your lower and upper limit of normal. And what those mean, best is you. So this is what you have done for that specific pulmonary function test. Okay, so the best, maybe, you do it 3 to 6 times, how many ever times, and they take those three times and they take the best of those numbers. So this is what you did for that pulmonary function test. This is you. This column here predicted, so that's around where you should be. So for this particular one, they should be around 4.13, and they did 2.53. So it's a little bit low. And this predicted number comes from the lower and upper limit of normal. So this is a good section to look at, the lower limit of normal, to see, where, if you're wondering, where do I fall? Like, what does this 2.53 really mean? Where does that fall compared to what maybe I should be at? You can look at the predicted or the lower limit of normal and maybe see where you might be. And then your percent predicted in this column here, this again is just the percentage of this number, this 4.13. So that's percentage of what you would predict based on your age, sex, and height. So first we're going to look at spirometry, and we're going to break it down even more. For just this top section, we're only going to look at 3 numbers, and that's going to be our FVC, our FEV1, and then our FEV1 to FVC ratio. So we're just going to focus on those. If you have a report in front of you, try to kind of take away all the other numbers and just kind of look at those 3 in that section, because this is what we use to monitor pulmonary fibrosis. So what is spirometry? It's that forced expiration maneuver. It's the most commonly used test of the pulmonary function. You can do these in an office setting, spirometry. You can often do it just in the office setting to diagnose some diseases. We don't use it to diagnose pulmonary fibrosis necessarily, and then it could be used to monitor progression. So this is a very commonly used pulmonary function test. The FVC means forced vital capacity. So it's really that total volume of gas that can be exhaled forcefully after you take a full inspiration. So if you're looking in this graph here, you have normal breathing. You're breathing in, you're breathing out, you're breathing in, you're breathing out, and then you're taking a big breath in. So this is as much as you can inhale, and then you're breathing it all out, but you're going past that normal expiration here, and you're going all the way, you're breathing all the way out, and then you're coming back into your normal breathing. So that's your vital capacity. Whenever you're doing this really big breath and then you're breathing it all out, that's what we're measuring. And this can be used, this is really information about the strength of your inspiratory muscles. So this is what we're following whenever you're doing that pulmonary function test. So again, it's just as if you were doing normal breathing in and out, and you're taking that full breath in, and then you're pushing it all out. That's that forced vital capacity. And just the VC means vital capacity. Whenever you're doing a forceful maneuver, it's called the forced vital capacity. The FEV1 is the forced expiratory volume in 1 second. So whenever you're doing that really big expiration, how much can you get out in that first second? And that's very valuable information for us. It can help us classify if it's a restrictive type of lung disease where you might have smaller lungs, restricted, you can't take a full expansion or exhalation. Or is it obstructive, which would be something more maybe like COPD. So this is valuable information for us. And just some examples of how we might get those numbers of just that FVC and the FEV1. So say the volume that somebody exhaled and when they're doing that expiration maneuver, and that first second was 4 liters, but the total volume that they exhaled was 5 liters. So total, when they're doing that big expiration, they got 5 liters out, but in the first second, it was only 4 liters. So that's the FEV1, the first second. So that the ratio from that is 80%. So that's just how we derive those numbers. Another example on a pulmonary function test report. So this is best. We're using an actual example. This is what somebody did, was 2.53. What they got out in the first second was 2.12. And so that is where we get that 84 percentage. It's a percentage number. Another example, 1.74 was that total liters that they were able to exhale. But in the first second, it was 1.2, and that's how we get that 69 percentage number. When we're looking at that ratio, so that number that we're deriving from the FVC and the FEV1, normal values around 70%, but it does tend to decrease naturally with age a little bit. However, in ILDs, we tend to see values that are greater than 80%. So that's because that FVC is smaller, because the lungs are a little bit smaller and tighter, but the air is exhaled quickly because you've got a lot of pressure kind of pushing it back together. So the FEV1 is also reduced. So sometimes it can be normal, but we tend to see that those higher numbers, greater than 80%. What are we using spirometry for? We use the FVC to monitor progression. That is one of the main numbers that we use. But we also use the diffusion quite a bit, but we're really looking at that FVC to monitor progression. And we would consider progression significant if we notice, around 10% or more change in that FVC over a year. All right, so if we notice that decline, quicker than that, if it's that 10% during a 6-month follow-up, we're going to have some questions. How are you feeling now? How did you feel during that pulmonary function test? Did you have a cold? Were you hospitalized, recently? Are you feeling back to your baseline? So we're going to get an idea of, was this a kind of a fluky number, or are you actually not feeling very well? And from there, we can decide if we want to order follow-up imaging to maybe see what's going on in the lungs. And then in some cases, we can even consider referral to lung transplant or re-referral if you've already been seen by someone. So that's what we're following, is that FVC. And again, that 10% change over a year could be significant. So some examples, and then in some cases, we might even see the FVC improve. So we can use it to monitor progression, but we also use it to monitor medication effectiveness. So if we're looking at a trended study, which is this portion here, we have our date, and this would be like July of 2023. And then we're looking here, there was a new therapy started for systemic sclerosis, interstitial lung disease. So we started a new medication. And we actually saw our FVC improve. So you can see it went from 2.72 to 3.21. So we would say, in this particular case, the patient felt better as well. They felt significantly better. So we would say that was effective treatment. But, if we saw that number continuing to decline, we might say, well, we need to make some other changes, do follow-up testing, and see, what something else might be going on. But this is why we follow trends. We are not looking at one specific number. We're following it over time based on how you're feeling, and then based on medication changes sometimes as well. So ultimately, our takeaways really are checking the FVC, the FEV1, and the ratio in the spirometry. We're using that lower limit of normal. You can use that to compare your results if you don't know where to start on that report. And then we monitor progression based on that change in the FVC. And that's just for your spirometry portion. Okay. Now we're going to get into some lung volume. So again, this is typically, we're on a lot of your reports. This is the second section. And we're really only going to look at one number in this section, and that's the total lung capacity. So in this example, it's the first number here, the TLC, total lung capacity. So we don't use lung volumes necessarily to monitor progression over time. We do expect the lung volumes to be smaller in pulmonary fibrosis because of that restriction on the lungs. So the lungs are stiff, and there's a reduced ability of those lungs to have a big stretch. So we're expecting to see small lung volumes. In this example, their lung volumes are 57% predicted. In some other lung diseases, you might see, like in obstructive type of lung diseases versus a restrictive, you might see something like 130%. It's really high lung volumes, large lungs. And just kind of a little bit of information on restrictive type of lung diseases that cause those small lung volumes. So what we're saying with restrictive lung disease is the expansion of the lungs is restricted. And I like this image here because this is the kyphosis. This is an example of a restrictive type of lung disease because the lungs cannot expand like they would like to. They're restricted. So you have smaller lung volumes. In some cases, you have that stiffness in the lung tissue. Sometimes it's stiffness in the chest wall. So examples of this, again, pulmonary fibrosis, neuromuscular disorders, obesity, scoliosis, and kyphosis like this. You're not able to fully expand the lungs. And this is in contrast to obstructive lung diseases, which are really characterized by those large lung volumes because air can be trapped after expiration, air can be trapped in the lungs. This would be something like COPD, asthma, or bronchiectasis. And then the last part of our pulmonary function test is a diffusion or gas exchange. That's the DLCO number. And this is the diffusion capacity of the lungs for carbon monoxide. And this is for us with pulmonary fibrosis, we're measuring the blood gas barrier. All right. So this is a section of the alveoli, this area where the gas exchange occurs. And this yellow strip here, this is the blood gas barrier in this pictorial. So you're seeing that the oxygen is not able to get through because there's a blockage or there's a thick scarred blood gas barrier. So you're not able to have the diffusion. And I really like this image. It can look a little complicated at first, but if you're looking at the big picture, the inside here is the blood vessel. So everything inside's blood vessel, everything outside is the lungs. And we're really only going to look at these two parts here. So I made those images bigger. But in image one, in the square, you can see how thin, and you really honestly can't even see it, how thin that blood gas barrier is. It's very thin, so the oxygen is able to diffuse easily. And this is, these are real images too. So it's not, drawing. I think it's really nice to be able to actually see this. So that's really thin compared to this section here, which is scarred and has some fibrosis in it. It's really thick. So you can see clearly how it would be difficult for that oxygen to be able to diffuse as easily as it would in image one here versus section two. So your diffusion on your pulmonary function test report is at the very bottom. And then again, you have all of these other numbers, but we're only going to be looking at our DLCO right there. And we're looking at, again, change over time. So we're going to be looking at trends. And along with the FVC, we use this diffusion to monitor progression over time. And you can see this is what you did for that particular pulmonary function test. This is the predicted, your percentage of predicted, and we'll talk about kind of what the percentage, what might be considered normal or decreased. And then you have your upper and lower limit of normal. So for this particular one, the lower limit of normal is 23, and they were able to get 14. That was their diffusion number. So it's decreased, definitely decreased, and that's 46%. Versus where we said around maybe like 70 would be a little more normal. So you can grade the severity of the gas exchange decrease. Less than 40% would be severe decrease, 40 to 60% moderate, and then greater than 60% would be like a mild decrease. There are a lot of things that can affect the DLCO, so that can change it. So we want to make sure we're talking to our provider about these results. You might get your pulmonary function test report and see that trended studies section and see a pretty big drop. Well, there's a lot of things that can affect the DLCO. I mean, just for example, so we have that thickness of the blood gas barrier, which is usually the case in pulmonary fibrosis, is that's a little bit thicker. But there's also anemia, so that can change the results of your pulmonary function test, pulmonary hypertension, and then also there can be a pretty significant change between pulmonary function test labs. So we take all of those things really into consideration when we're looking at a DLCO number. Say somebody had a pulmonary function test done in Colorado, and then they come to Tucson, Arizona, and they're doing a pulmonary function test in a different lab at a different elevation. They require different oxygen, at each place versus elevation versus in Tucson. So that can change pretty significantly. I mean, I've seen them where they jump up significantly, like they're significantly improved. And that might not be necessarily a measure of the diffusion, but just the difference in labs or the difference in the technician that you had. And that can really change across the board with pulmonary function test, really the different labs that you go to. So these are all different things that we take into consideration. So it's really important to talk to your provider about your results whenever it comes to all of the numbers, but the DLCO as well. And then you will be asked to take off your oxygen for the DLCO test. So if you are requiring really high flow oxygen, you might not be able to perform this, and we might be doing another measure of gas exchange, maybe like a walk test to see, has your oxygen requirements have they changed significantly? So sometimes we can't get these numbers. How often do we need to repeat the pulmonary function test? That can really depend on the specific type of ILD someone has, as well as the disease course. So, are we expecting a naturally progressive type of interstitial lung disease, or is this something that's typically not very progressive? Initially, sometimes we monitor a lot more frequently. So, if somebody is newly diagnosed, we might be doing them every 3 months for a while. And the reason we do that is because with pulmonary fibrosis, we don't have biomarkers or blood tests that tell us this person is going to progress quickly versus somebody else might progress not so quickly. We don't know that type of information. So we might get them a little more quickly to see what kind of trajectory somebody might be on. And then depending on, oh, these are looking pretty stable, then we might space that out to every 6 months or every 12 months, depending on the type of lung disease that you have, the type of pulmonary fibrosis. But in general, you can expect to do them quite a bit. And I know it's not an easy test to do a lot, but it's really one of the best things that we have to be able to see what type of trajectory someone's lung disease might be going, and looking at those trends. So we really make sure we don't ever take one number and treat based off of that. We're looking at change over time. So this is a trended study example. So if you have this type of report, and most of them will be about the same, we have our dates here. So it usually starts at the later date to the most early date. And then you have your FVC column in this green, and then our red column here is the DLCO. For the most part, you can take out all of these other numbers to make it a lot more simple. And then you have your weight in this column, which can sometimes be helpful to look at as well, because that can affect your pulmonary function test, as it might be in this example. So if we're looking at this example here, we're looking at our date. So in May of 2019, we had an FVC of 2.49 and a DLCO of 14, and we're going to go up. So we're looking at the change over time, and it stays about the same whenever they do it the same than when they do it the next time. And then you can see it start to gradually decline. And then our DLCO, you can see a pretty big drop there in the DLCO. So in this particular case, we might be wanting to get another CT scan to see really what's going on in the lungs, or follow up different type of testing, maybe an echo. We're going to be evaluating a lot of things looking at this type of pulmonary function test. Another example, again, we have our date and where this blue arrow is, our dates, and the green arrow, our FVC, and then in the red arrow, our DLCO. And overall, you can see these results really stay the same. So our FVC in November of 2021 was 2.7. And then it was the same really by September of 2023, and really not too much of a drop into January of 2024 here. But we noticed something really big here once we get to um, October of 2024, and that's mainly in our DLCO. So our FVC is staying the same, really, 2.69 to 2.71, but we see a really big drop in our DLCO. So this is an example of, what do I make of this? If you see something like this on your report, this would be something you definitely would want to talk to your provider about, and they might get follow-up testing, a CT scan, maybe checking out your heart, checking your blood counts to see why there might be such a big drop, checking your oxygen levels. So they don't always go hand in hand, and this is where it can be really tricky evaluating your own pulmonary function test, because there's a big difference in your DLCO, but there's not so much of a difference in your FVC. So really, it can be even tricky for providers sometimes to determine what's going on here. And this is an example I showed earlier, but again, it shows the improvement in our FVC in the red circle there from 2.7 to 3.2. And that was because of the medication change. So you can see a lot of different things, but these trended studies can be helpful in following that change over time. So, whenever your provider is reading your report, there's a few things that we're looking at. First, we typically just look at the flow volume loops. So, we sometimes we can see if there's artifact, which would mean maybe somebody was coughing through the test. They couldn't quite get all the way through. So, we look to make sure that you can take the full breath. There's no presence of a lot of coughing, or there's other little things that we can look at. We look at the ratio. So we're going to see, this is a restrictive type of lung disease. So again, above 70 or 80%. And then we're going to compare that FVC and that DLCO to your past studies. And really those are the main things that we're looking at whenever we're checking out that pulmonary function test in comparison to your past ones. Whenever you're doing your pulmonary function test, which I'm sure a lot of you have done several of them, I always like to just point out that the best effort does count. It's an effort dependent test. So if you aren't feeling well, say you're not able to push all of that air out like you were the last time you did the test, that's going to reflect on the numbers, that FVC number. So we want to make sure we're treating your actual lung function numbers, not, maybe I just didn't feel as well as I could have. So I always tell people it's okay to reschedule if you are sick, because again, we want that baseline everyday lung function. We don't want to know what it was maybe when you had a cold. We want to know, how it is on your baseline. And then deconditioning can make results look worse. So if you've had a hospitalization and you're feeling really weak, then you could still do your pulmonary function test, but we just keep in mind, maybe you just got out of that hospitalization and we could see that improve when we do it in 3 to 6 months, maybe after some exercise, some pulmonary rehab, something like that. And that can improve your pulmonary function test as far as the muscles go. So that force that you're able to give behind the breath. We do advise just avoiding the heavy meal 2 hours beforehand, so you're not able to take those full breaths whenever you have a full stomach. No alcohol 8 hours before the test. Avoiding really heavy exercise right before the test. Just wear comfortable, loose-fitting clothing, something that you're able to make sure you can take full breaths in. And then, of course, no smoking. At least 1 hour before the test can affect your results quite a bit. So things that you can do between testing, exercise is a great thing to do between testing. So this can improve your conditioning and it can improve your pulmonary function testing. It doesn't have any effect on the scarring in the lungs or anything going on maybe inside the lungs, but it can really have a big effect on the force that you can put behind a breath. So it can help you with breathing exercises, can help with your cough strength, so you're able to give a more forceful cough and clear secretions. So good exercises to do would be like walking, stationary bike, any type of resistance training or weightlifting. And then to keep in mind that you might need oxygen in order to exercise. You might not need it necessarily in your day to day, or maybe you don't need it during the 6-minute walk test whenever you're doing just that walk test in the hallway. But if you're trying to exert yourself a little bit more, it's okay to use oxygen. In fact, I think it's very important to let people know that we would rather you use oxygen in order to stay active rather than avoiding activity due to shortness of breath, because that just contributes to that deconditioning, those weakened muscles, that less forceful cough. You're not able to really do as much. So you might need to put a little bit of oxygen on in order to take that walk, or maybe keeping that large concentrator by a stationary bike or a treadmill so that you can have that continuous oxygen while you're exercising. And that can make a big difference on your pulmonary function test. Pulmonary rehab, of course, goes with exercise. So we don't necessarily need to order pulmonary rehab right off the bat for everybody. Pulmonary rehab can be good if following a period of maybe a hospitalization, or if you're feeling weak to begin with and you need help learning how to breathe either with oxygen, learning how to breathe while pacing yourself. So you can't do all of your activities in one day. Maybe we need to space those out a little bit. And so pulmonary rehab can be really good in helping you manage those types of things. And it can improve your physical function, shortness of breath, mood, quality of life, and those are things that we've seen through research. And they don't, again, just help with exercise. They talk about disease management strategies, your oxygen use, and then activities of daily living. Some good online resources. I mean, you can do a lot of pulmonary rehab in person, but if that's not an option for you, the Pulmonary Fibrosis Foundation has a online pulmonary rehab toolkit on their website. So that has flow sheets of checking your vital signs of your oxygen levels, your blood pressure, your shortness of breath scores. So it shows you ways to do that safely, and then there's videos that can safely show you how to exercise at home. And then you can also use this AACVPR, the American Association of Cardiovascular and Pulmonary Rehab. They have a program directory. You can go on their website, put in your area code, and it'll show you some places near you that offer pulmonary rehab if you're unsure what's in your area. I always think it's important to mention oxygen. So this goes along with exercise, knowing your oxygen equipment. You can't properly exercise if you don't know your oxygen equipment. So I always like to talk about this briefly. So you have a pulse dose flow. This is usually your small concentrators. There's only one device that provides up to 3 liters per minute continuous. So it's really not adequate for anyone requiring more than 3 liters. So maybe it might be adequate just walking into appointments or through the grocery store. But if you're really trying to exercise, you might need to use that big continuous oxygen for your exercise. And you can get oxygen if you're needing it for exercise. So you can get it if you might not need it again day to day, but if you need it for more strenuous activity, we can still get that approved. And then another thing between testing is joining support groups. So they discuss pulmonary function test results. We discuss exercise that's safe for you, and then discussing oxygen and equipment. So just being familiar with all of those tips and tricks. And there's usually providers from pulmonologists from your community or from university medical centers that are giving talks on pulmonary function test, just to help you understand things a little bit more. Right. I think I am done. So I think we can open it up for questions. Hope that wasn't too fast, but I really wanted you to be able to get something from it going through some examples.
That was really fantastic. Thank you so much.
Yep.
We have a lot of great questions. So I'm just going to start and we will take as many as we can. We've got a good amount of time. And I may ask you, hopefully you're okay with this, Mary Beth, to go back over some things since it was a little fast that people had some interest in maybe just reviewing again.
Okay.
We had a few questions about that. One question I have is, do you feel like there's a certain component of the pulmonary function testing that your respiratory team is more concerned about maybe than others, or is it that you have to kind of take a step back and take the whole clinical picture? Is there one area that you know gives you more information than others?
Yeah, I think the things that we're looking at the most are the FVC and the DLCO. We're looking at those in their change over time. So again, not looking at just one number, but looking at the FVC and the DLCO and their change over time. So taking the clinical picture is very important as well, because there's a lot of things that can affect your pulmonary function test. And I've seen, it didn't look so good, and they said, well, I didn't feel very good during that test. And so we get a follow-up pulmonary function test, and it goes right back to where it was before. So really evaluating the patient and taking that into consideration is very important. So sometimes you look at a report before you see the patient and like, well, this doesn't look too good, but you go in and they're feeling really good. Well, maybe that's something we need to repeat and reevaluate.
Absolutely. That's a great point to be made, and it addresses really another question that we had. If there is a big change, like a bad test, something's much lower than it was before, how concerned should a person be about that? And I think your point about putting that in context of the test of that day, how they're feeling, and if those things are really in alignment, and then you showed the trending, which I thought was so helpful. That's what I, do in clinic is create a chart like that for myself to look at. Um, and I'm not necessarily thinking about everybody's percentage that day. They make an A, B, C on the test, but what do they look like in context of their own historical and baseline values? And then you have to take that in the context of the whole clinical picture. How are people feeling, functioning at home? Has their oxygen requirements changed? Do they have new imaging that shows something different? So it is sort of a piece of that whole puzzle. Um, the Talk a little bit, if you could, about the relationship between DLCO and oxygen levels on formal testing in the clinic. They're
Yeah,
related, but a little not as closely as one might think. One can't exactly.
right. Yeah, like the like when you're doing a walk test or yeah,
Right.
sometimes there's so many things like I said that can affect the DLCO. So your oxygen levels could be normal and your DLCO might be a little bit low. And sometimes we see that we see it quite a bit actually. So if we see that maybe your DLCO is a little bit low, we might want to be checking other things. So maybe your blood counts because anemia can cause that DLCO to be a little bit low. We want to say, how do you feel like you performed on that pulmonary function test? Do you feel like maybe you were a little weak? You couldn't, uh, maybe you were coughing a little bit. If you had to take your oxygen off, you were just trying to do it fast, so you weren't able to get a good reading on it. There's a lot of different things that can affect that. And then checking an echo as well. So we always want to make sure we're checking your heart to look for other causes why that DLCO might be low. Do you have anything to add to
No,
that?
I think that's all really good points. I think that there's a lot that's impacted by that 6-minute walk test as well in terms of what that oxygen level translates into. And I find that surprisingly enough, one might think that a diffusion capacity measurement, um, all other things being equal, for somebody who doesn't have anemia and doesn't have pulmonary hypertension, things like that, their oxygen levels are not necessarily comparable, right? That this person with a diffusion capacity in the 50% range doesn't necessarily need supplemental oxygen like somebody else that has a similar DLCO. And so that really is an individual um, assessment of oxygen need and exercise capacity, complemented by the diffusion capacity. So I think those are all important things to look at.
Yeah,
Um,
and I think that's another reason why we don't necessarily give people a stage because there could be such big differences in what the DLCO or FVC looks like compared to how the patient is actually feeling or doing.
Absolutely. And while we're talking about DLCO, quick, just briefly on the difference between when we see it on the list, uncorrected and corrected DLCO. So it's a question that
Oh
comes up
yeah.
a lot, I think.
Yeah,
Yeah,
so it's corrected for your hemoglobin. So if your hemoglobin is low, because that's what carries your oxygen, then it can make that DLCO low. So if there's one available, so if you maybe had a blood count recently, then they'll look through the chart, they'll see that hemoglobin's available, and then they'll take that into consideration.
I will say that if you do not input in our institution, if you do not input the hemoglobin into the machine, it will not correct for that hemoglobin. And so I tend to track uncorrected DLCO simply because most of the time there's not a closely correlated hemoglobin to look at. But then you always have to go back and say, okay, what is their hemoglobin if there's a change, just like you were mentioning. Um, a little bit of switching gears, but not too much. Talk about the differences that can come up in height. So this happens sometimes. If a respiratory therapist who's doing a pulmonary function test keys in a height that is either, they mistype it in, or maybe they misread it from from the intake sheet, or somebody wore high heels and didn't take them off to get their height measured, something like that. So there's a difference in height from the prior PFT to the current one. Talk a little bit about how that impacts what you're seeing in the results.
Yeah, and it's the same probably for weight too. I mean, if you have a significant weight change, at least with the weight, it's noted in our reports on the trend in the trends, so you can track that pretty easily. But if you're noticing a really big change in the pulmonary function test, I always go back also and look at the height and the weight together to see if there's a something that's different. So I mean, I think it can change your pulmonary function test quite a bit, but I just always keep that in the back of my head. If I notice across the board the numbers look a little different, then I'm looking at my height and weight to make sure there's no big change.
And to be specific about that, that would be a change not in the, let's say, forced vital capacity, the number, the amount of air that's moved, like the liters that are moved. It's that will be the same regardless of the height that's keyed in, um, uh, or any of the other corrections that go into the normal value calculation. But it will change the percentage that reads out, so
Percentage.
the percent predicted, and that's why when you're comparing a person to themselves over time, it's actually really best to compare their absolute value of liters for FVC, for example, over time, because there can be differences um, in the percentages if there is, number one, an error or a change in some of the parameters that go in to create the normal values, or between centers, or if in your center they change the reference values, because there are different sets of reference values, and so there, you may not be playing with the exact same set of rules there. So using that, but leaders are leaders regardless of where you are and how tall you are, and so that's a good measurement to be looking at. I saw a question I really liked. Let me go back to it really quickly. It was about just the sense of what is forced vital capacity. I think you described it a little bit, but would it be similar to something in some people's everyday life as in a yoga practice? Would it be sort of like a deep cleansing breath? Or how would you, can you
Yeah.
describe that for us again?
Yeah, and I can go back to, let me see if I can still go through my slides here. Because I think this visual is helpful in trying to really see what a forced vital capacity. I think describing it as like if you take a big deep cleansing breath in and out, that's helpful, like yoga breathing. But I think this visual is helpful because it really shows. First, it shows normal breathing. So this is kind of your breathing that you're not even thinking about, just normal breath in, normal breath out. Whenever we're taking a big breath in, we obviously we have more breath that we can inhale and we can hold in our lungs, and then we have more breath that we can exhale even whenever we're just doing after a normal breath. So if you're just doing your normal breathing here, then you take that full inhale. So if you're doing like a yoga breath, all the way in, and then you're pushing all the way out, even past where you normally would push your air out in a normal breath. That's all the way down here. This is the normal breath that you're exhaling, but you're even going further than that. That's a vital capacity. So everything that you breathe in and then everything that you breathe out is considered the vital capacity. And we call it the forced vital capacity because we're doing it in that forced maneuver to get that information about the strength of the respiratory muscles, if that's helpful.
That is helpful. Stick with this one though, because we have another one on the theme, and it's I think you said this, but let's just be really clear and specific. Explain the difference for us between forced vital capacity and total lung capacity one more time.
Yeah, the total lung capacity also, so we can't, whenever we're just doing a normal um, vital capacity, we can't account for the residual volume, for example, like everything else that encompasses that can stay in the lungs. So everything else that the lungs can hold. So our residual capacity is whenever we're breathing just normally, there's a little bit of air. Even whenever we're doing that deep expiration, we maybe have a little bit of extra volume that's left in the lungs. So total lung capacity accounts for all of those lung volumes. How much you can breathe in, how much you can breathe out, how much is left at the end of the breath. That would be the total lung capacity.
That's true. I think this graphic is just really helpful.
Yeah.
When I was studying this initially, it had a little pocket like guide to respiratory function, and these types of images I think are super useful.
Mhm.
Um, so here's a question, and I'm going to ask it, but I'm going to frame it a little bit differently. The question is asked was, can steroids change your test outcomes? And I'm going to change that on purpose to say, in what scenarios might use of steroids change outcomes of your test?
Yeah, so there's if we're getting a pulmonary function test during someone's exacerbation, so say you're not feeling very good, and we evaluate that. We ask you, how were you feeling during the test? And you've not been feeling very good recently, and we need to give you a little bit of steroid for that exacerbation. Then we might see that FVC, that pulmonary function test, improve. There's also different types of interstitial lung diseases that are more maybe inflammatory or like a hypersensitivity pneumonitis that are really responsive to steroids. So we expect as a mainstay of treatment, not just as a exacerbation means, but as one of the mainstays of treatment, that steroid would improve that. And if we expect steroids to improve a pulmonary function test based on the type of lung disease we think you have, and it doesn't, we need to go back maybe to those multidisciplinary discussions and rediscuss the treatment plan because that steroid didn't have the effect we thought it should have whenever we treated you with it.
Yeah. Um, I know you had some nice graphics in your presentation showing pulmonary function reports. Can you pop over to one that shows the different labels, pre, pred, LLN, and ULN? Because we had some questions about those abbreviations, and I think that
This
it's
this
helpful
one
to
had
say
every.
there's no definition of them on those reports when we see them. Can you walk through those for us?
Yes, the pre-bronchodilator and post-bronchodilator, is that the question?
I think it's if you would, pred, percent pred,
Oh, okay, yeah,
LLN,
here.
and ULN. Uh-huh.
Yeah. I'll look over those, but just since I'm on here, the pre-bronchodilator versus post-bronchodilator, that's not on every report. It might say post, but there's not always numbers there. That's if we're doing a test with an inhaler. So sometimes we'll get the pre-bronchodilator. So it's just a normal pulmonary function test. Then we'd have you use the inhaler. And if you get benefit from it, we'll see a change in the bronchodilator numbers. So you can get these. We don't get them every time. Sometimes we'll just see if there's a response to it and then we don't get it anymore. So you can do that, but sometimes you can just take away that post bronchodilator section. And then, yeah, this section here. So kind of going over that a little bit more. Let's see. So in your best section, so again, this is what you're doing. This is your pulmonary function test for that specific day that you did the pulmonary function test. So this person for this FVC maneuver, they had 2.53. This is what you did. And then you're predicted, that pred, that means predicted. So this is around where you should be. So they get this predicted number based on this lower limit and the upper limit of normal. So what these lower and upper limit of normal really mean is, for somebody with your same age, sex, and height, they should be within this range of this. For this particular person, it's going to change, but it would be 3.27 or 4.99. If you're within that range, then that would still be considered a normal FVC number. If you're lower than that, then it's going to be, abnormal, or if you're higher than that, which we don't see a whole lot, but you'll see, you can kind of get a general sense of where you would lie on your pulmonary function test just by looking at that lower limit of normal. So for this one, it's the lower limit of normal is 3.27. So that's within that range. It's still normal, 3.27. But for this pulmonary function test, this person did 2.53. So we can tell that it's reduced based on the lower limit of normal. And if you're wondering, what is the percentage? What is 2.53? What's that percentage? It's the 61 is the percentage of that. But sometimes it's kind of hard. Like, what does 61% mean? I think that lower limit of normal can be really helpful if you're just looking at your report, kind of wondering what your specific numbers mean. Does that make a little more sense?
Yeah, I think it's really helpful. Thank you. Um, I have a quick question, and I'm actually interested in Mary Beth, your experience because I have limited knowledge outside of my own institutions where I trained and where I've practiced. But we have one patient who said that that beyond being difficult to perform, the pulmonary function testing is uncomfortable because the seat in the booth is really hard,
Yeah.
and and that is true at my institution. Do you have comfortable seats in your booth or your pulmonary function
Yeah,
testing, or do you know?
I wouldn't say it's comfortable.
Okay.
I've done it. I've done a pulmonary function test in our lab, and yeah, it's definitely not comfortable. It's a hard test. I know we make people do them a lot, but it's definitely not a comfortable test. So, it's hard to do it every 3 months or even every 6 months, and then say give your best effort every time because it's definitely not easy. And that's why maybe wearing something comfortable, just kind of knowing what you're getting into. It's not uncommon for people to do better their second time because they know what to expect. And that's why, again, why we do the so many overtime because maybe you just weren't comfortable in the booth that day and didn't do as well as you thought you could. So we're always looking at everything over time.
Right. Well, this has been wonderful, Mary Beth. We are near the end of the hour. Can you advance to the towards the end of the slide deck for me? I just wanted to remind folks if you have a couple of minutes left here, if you would like to download slides, they are available on the chat where um, we have put a downloadable link there. We've also included a link to one of our pulmonary function testing educational resources on how to read your pulmonary function test. You can download that and take a look at it as well. Um, we would like to remind you at the end of this session that we will have an opportunity for feedback. So please stay and give that to us if you have a moment. It won't take much of your time and we value your input. We would love for you to save the date. We do have a couple of future webinars, times and dates we want to give you. We have launched a new webinar series, our clinical trial innovation series, which you may remember from the PFF Summit as well as from our education symposium. Well, we are expanding that into webinars throughout the year to give people more opportunities to see what is going on and new in the space for our clinical trials with our industry partners. And so our first of those webinar series will take place on February 19th, and that will be at 12 p.m. Central Time, 1 p.m. Eastern. And our next disease education webinar event will be on March 26th at 12 Central and 1 p.m. Eastern. Do you have one more slide there, Mary Beth, to thank our sponsors? Yes, we do want to thank our sponsors for today's event. And I mostly want to thank Mary Beth for being here. This has been a wonderful session. Thank everyone for your attention and for all your engagement and questions today. And we will see you in just a few weeks. Thanks so much. Have a great day.
Thank you. Thanks. You too.